Hi guys, Dr. Gillard here. It's week 8. This is CVPP, lecture spring 2020. Here we go. So we just talked about pulsus paradoxus. Remember, that was the paradoxical pulse. When you take somebody's radial pulse and it's beating along and all of a sudden it disappears, you can't feel it when they breathe in, but when they breathe out, you could feel it. And we said cardiac tamponade is the main cause of that, where the pericardial cavity gets filled up so much that it strangles the heart to the point where when you take a deep breath in, the blood sucked into the heart can't expand the heart physically, and instead it pushes the interventricular septum into the left ventricle, and therefore it greatly reduces the filling volume of the left ventricle during inspiration, and therefore the output of the heart drops because there's not as much blood to eject from the heart. Kussmaul's sign is a similar type of a deal, only it's a more severe restriction to incoming blood. That's how I think of it. It's more severe. And it occurs when the external or internal jugular vein, you might even see an internal jugular vein pop out, but it occurs when the external jugular vein fails to diminish when you take a deep breath. See all the blood right here in his external jugular? If you take a deep breath in and there's nothing wrong with his heart, this will disappear, or it'll greatly reduce in size. Why? Because this blood just got sucked into the heart and it was pushed into the lungs. But if you can't get blood into the heart, if there's I guess I could draw his, ridiculously too big, but there's his atrium. So when you take a breath, that blood should go right in there and then be processed into the lungs. But if there's a beaver dam here and you can't get in, maybe it's some stenotic tricuspid valves and the blood can't get in. It can back up into this. It can actually get worse, make this thing bug out even more. Okay, that's one cause of it. Another cause is a severe strangling of the heart, as we'll see. Is described and named by Kussmaul way back in the 1800s. He also discovered pulsus paradoxus. This was his type of thing. The mechanism for this is still a little controversial, but we think we have a pretty good story, but there maybe in the future turn out not to be the mechanism, but let's tell you what we know so far. And I should say, for all practical purposes, these patients are going to have pulsus paradoxus. On top of this, not only are they going to have pulsus paradoxus, they're going to go a step further. Their right heart is so squeezed, and you can't get blood into it so bad that it's going to affect the jugular vein. And that's Kussmaul's sign. But they will have pulsus paradoxus. Some proposed etiologies, so something that strangles the heart more fiercely than cardiac tamponade. Remember, that's a fluid. So fluid's going to have a little bit of stretch to it. So the two main things, when you think Kussmaul's sign, you could almost think right ventricular failure. I could have almost added that in, but the research says so, but the board books don't. So right ventricular failure is a close third. We'll look at that in a minute, though. But constrictive pericarditis and restrictive cardiomyopathy. And we'll take a look at both of those. And this occurs when the pericardial cavity gets filled. Well, this one, constrictive pericarditis, occurs when the pericardial cavity gets filled with fiber, scar tissue. And people who produce scar tissue more than normal, like people with sarcoidosis or amyloidosis, those are the type who get this, but it doesn't have to be from them. Sometimes it's idiopathic. Restrictive cardiomyopathy Oh, I'm sorry, that's restrictive cardiomyopathy. That's where the myocardium itself gets filled up with scar tissue. And those are from the kind of scar tissue diseases, forming diseases. So those are sarcoidosis and amyloidosis. We'll look at the causes of constrictive pericarditis in a while. That's the one sometimes it can happen idiopathically. We don't know how it happened. All right, and again, these will also cause, probably the first thing that will appear will be pulsus paradoxus. And then it goes on to a Kussmaul sign. Might be caused by something that physically blocks, like I did in my little demonstration there. So I just showed you pulmonic valve, not mitral, that's an error, bad. That's the left side of the heart. Just changed that this morning. Tricuspid. Right, I will definitely fix. Let me write it down here. First fix, 238. Yeah, so it's got to be on the right side. A beaver dam anywhere on the right side of the heart. What could be a beaver dam affecting the flow of blood through the right heart? Well, something physically blocking the flow, like a pulmonary embolism stuck somewhere, maybe in the pulmonary trunk, or a stenotic tricuspid valve, or a stenotic pulmonary valve or pulmonic valve, AKAs, or just right heart failure from, I think I can add this in here as well. What causes right heart failure? Good, COPD. What's COPD? Chronic bronchitis, emphysema. Medical students would probably add chronic asthma in there as well, but it's not, the board books don't say that yet. The chiropractic, when I say board books, chiropractic board books is what I'm talking about, because I am teaching at a chiropractic college, and this is their lectures, if anybody's kind of eavesdropping on these things. So check with your own boards to see what books are. They're probably going to be Robbins and Rubens anyway. Medical school, I think they are. Okay, let's not be rambling now. All right, so I think that's enough about that. So inspiration sucks blood into the right heart. It can't get out, right? And it backs up just like that picture I drew. Also backs up into the liver as well, right? In fact, backing up into the liver, we have it. That brings us to a new test. I don't think you know this one. Hepatojugular reflex test, which is often called the AJR, or the abdominal jugular test, or abdominal jugular reflux test. Let's see. Used to confirm the beaver dam. Yep. So let's talk about this test. So the patient is supine, 30 degrees incline. So he's supine, but if you can lift his chest, kind of incline his chest by 30 degrees, that's better. You rotate his head away to the left because you're going to be observing the right jugular vein. And then you're going to push your fingers. This isn't the most pleasant feeling in the world, but you're going to stick your fingers right under the right costal margin and push upward inferiorly, I to S, into the liver, and then hold it for 10 seconds. So what you're doing is you're squishing the liver, you're squishing the blood out of the liver. So the maneuver forces blood out of the liver and into the inferior vena cava and into the right atrium. It's just like taking a deep breath. You don't want him to take a deep breath with this test, though. If the right heart can't accept or accommodate that incoming blood, where's it going to go? Yeah, it's going to go up into the jugular veins. It's going to make the jugular veins bug out. Right? Some authors say that you should only look at the internal jugular, which is really impossible to see, I think, because it's wrapped in the carotid sheath. So I would say that to those authors to maybe recheck that again. Other authors say the external jugular. Positive finding is the jugular vein bugs out. And the sensitivity is crummy on this. So just because the test is negative doesn't mean you have problem with right heart failure or restrictive cardiomyopathy or any of those other diseases that fill up the pericardial cavity. But if it's positive, this kind of like EMG NCV studies have a very high specificity and a low sensitivity. So specificity is 94%. So if the test is positive, you got definitely a beaver dam or something strangling the heart. So it's very specific. The rate of false positive is quite low. Okay, so here's a patient. The doc was pushing, actually you can go see it here. The doc pushed into her liver and held it, and you could see her jugular vein pop out. It's her external jugular vein just popped right out. So that's the hepatojugular reflux was demonstrated. Test was positive. Okay, here's a patient with his head is up here. This is just his neck. I think it's a her actually. There's the nose. They're laying face up, but you can see the both. You could see. I think that's like an anterior. There's a couple of the jugular veins can be. There's different pieces we didn't really study in anatomy. There's an anterior piece and some other little pieces here, but bottom line is they took a deep breath in and the jugular vein got worse. It bugged out more. So this patient ended up having constrictive pericarditis. What do you think of this one? Oh, that's not good, is it? So had her take a breath in and the jugular popped out. But you see something else, right? Something else really bad. Submental node or submandibular nodes really, really swollen. I think this is throat cancer. What are the two most... Ooh, this has been asked a lot, hasn't it, all these stars? What are the two most common causes of constrictive pericarditis? What are the two most common causes of Kussmaul sign? Constrictive pericarditis is about a third of these patients. So that's pretty common. And the pericardial cavity gets all scarred up. I think we'll look at it a little more closely. And then, therefore, when you take a deep breath, the right heart can expand. And, yeah, you get positive Kussmaul sign and a positive pulsus paradoxus. Number 2 is called restrictive cardiomyopathy. Ventricles can expand well during inspiration because of myocardial fibrosis and thickening. So these are the diseases like sarcoidosis, amyloidosis. Hemochromatosis is another one that's really rare. But they scar up things. They make tissue thick and scarred and tough and non-flexible, and that can happen to the heart, walls of the heart, and then the heart can't expand when you take a deep breath and suck blood in. Pulsus paradoxus would be present on that patient as well. So just to review, cardiac tamponade right here we looked at last time. And remember, cardiac tamponade's not bad enough to cause a Kussmaul sign usually. It's probably if it gets like ridiculously, it probably would cause Kussmaul's as well. But usually it's not. It does cause pulsus paradoxus. All these conditions cause pulsus paradoxus. And Kussmaul sign is seen in both constrictive pericarditis and restrictive cardiomyopathy. How about some other causes? We kind of said these already. Any right ventricular dysfunction or right heart failure. So the patient had a myocardial infarction on the right. Now the heart's not working good. Then the heart's going to act like a beaver dam. Chronic pulmonary hypertension from COPD, maybe a chronic pulmonary emboli, which have scarred up the microcirculation, could do it. Maybe one big pulmonary embolism that's stuck somewhere in a pulmonary vein, causing a beaver dam. Maybe it's lung cancer. Lung tumors can compress the pulmonary arteries and veins and cause a beaver dam and cause pulmonary hypertension, and they can ruin your heart. You'll probably die of the cancer before it ruins your heart, though. And then we already talked about stenosis. What do you do for treatment for cardiac tamponade? They got to go to the ER. So they do a procedure called pericardiocentesis, where under ultrasound they stick a big needle very carefully, not to puncture the heart, and they stick it into the pericardial cavity and drain the fluid out. Remember cardiac tamponade? I guess we came out of a beaver dam, did we? We're finishing up cardiac tamponade. Constrictive pericarditis. God, that slide's kind of out of place, isn't it? Constrictive pericarditis. I might even make a note of that. 249 out of place. Constrictive pericarditis, kind of sad. It's also called adhesive pericarditis. So it's more than just pericarditis. We talked about inflammation of the pericardial layers, which sometimes could cause tamponade if got enough fluid secreted from the inflammation of the pericardial cavity. But a thick sac of tissue grows within the pericardial cavity. So we have scar tissue growing inside the pericardial cavity and eventually makes that pericardium impossible to stretch. Pretty rare, about the same as Marfan syndrome. Clinically important diseases of the pericardium. So there's 3 causes of constrictive pericarditis. One is acute pericarditis. So about 9% of patients who come down with acute pericarditis, for whatever reason, they don't drain the fluid that builds up in the pericardial cavity. Instead, that fluid turns into a scar tissue. We don't know why that is. It could occur months or years following the pericarditis. Not in our part of the world, but this is still a big problem. Tuberculosis can also invade the pericardial cavity and cause a fibroblast heavy inflammation, and scar tissue is laid down. And then sometimes they don't know what it is. They try to drain the pericardium or stick a needle in the pericardial cavity. They can't find anything. It's probably a lingering virus. Maybe they had a pre-existing undiagnosed pericarditis. Maybe it was an autoimmune attack of something. Whatever it is, sure is ugly. So there's the fibrous pericardium and a fatty heart. But look at all this. There's the part you shouldn't ever be able to see a pericardial cavity. It's just all that is just scar tissue. So literally strangled this person to death. This patient died. Okay, tenaciously thick scar tissue. That's constrictive pericarditis. What's the fix? There is no fix. There's a fix. You just take off the pericardium. Remove the pericardium, and there you go. No pericardium. You probably lose your sympathetic and parasympathetic nerves as well. Cardiac tamponade versus constrictive pericarditis. We kind of talked about this, didn't we? How do you clinically differentiate cardiac tamponade from constrictive pericarditis? Constrictive pericarditis is really constrictive. So not only do you have pulsus paradoxus, you have positive Kussmaul sign. Cardiac tamponade it's constrictive, but not crazy constrictive. So you won't have a Kussmaul sign usually, but you will have pulsus paradoxus. All right, so we're entering a new category now, and we're going to get into some kind of tough stuff. We're going to start talking about electrical arrhythmias of the heart, supraventricular tachycardias, and a lot of uncharted waters you guys don't know, and people have trouble in the last test. This is the spot they have trouble. I strongly urge you to go to this link on my YouTube channel for physiology of the heart and get up to speed with that, because if you don't understand the physiology of the heart, I'll do like a couple slides, but I just don't have time to redo this. So it's like an hour lecture probably up there to get you caught up to speed. I will go over the pathways, but you've got to know the normal flow of electricity through the heart. Normally, the SA node is the pacemaker. If you watch that, this is Usain Bolt. It's the fastest depolarizer. It sends out a spark. There is a very fast tract that runs from the right ventricle to the left. I'm sorry, from the right atrium, because this is in the right atrium, kind of by the jugular or superior vena cava. There's this. It's almost like having another SA node over here in the left atria. That's how fast this is. So it shoots the signal over here, and then the wave of depolarization comes across the atria. Everything's depolarizing. We have 3 similar tracks heading toward the AV node here. These are internodal pathways. All right, they're fast, but they're not as fast as this. Most of the signal, or the left atrium, is almost depolarized by the time the right atrium is depolarized and these signals reach the AV node. So that's important to understand the concept of the Bachmann's bundle and these internodal pathways. And then what's the job of this AV node? Good, it slows the signal down. No matter who gets here first, the signal is slowed down. So we have time to contract. That's atrial systole, right? That's topping off the ventricles. We need to squish some more blood in there, and that gives us time to do that. And then after the decremental conduction period is over, the current rips down. This is called the bundle of His, goes into the right and left bundle branches, then it goes off into these Purkinje systems to every nook and cranny of the heart. Okay, that's kind of the pathway. Decremental conduction is an important concept. Remember, the AV node slows the signal down. And this is the actual decremental means the faster the atria beat, the more the AV node slows down the signal, which is a good thing. And that is super important for surviving some of these supraventricular tachycardias. For example, atrial fibrillation, on average, the atria contract 550 beats per minute. Your atria can do that. You don't need your atria. You won't have a perfect ejection fraction. Your ventricles cannot contract that fast. You'll die, and it'll kill you. But luckily, that AV node will slow down that signal to maybe 160 beats per minute, anywhere from maybe 120 beats, maybe 200 beats per minute. But usually, it's 160, 170 beats per minute because of that decremental conduction. So that's a lifesaver. ECG. Okay, this is the tough area we're getting into now. I built this part of the course with these 4 books mainly. There's 2 of them if you want to read about some of this more and get into this, because this is within the scope of our license. I only have like 2 weeks to teach you this stuff. I need a full class to really get into it, but our license would allow it if you become proficient at it. But anyway, this is a great book right here. My goal is to my daughter's an RN, and I watched her go through school. I was surprised they got a lot of ECG stuff. So my goal is to make you at least on par with them and know some of the more common supraventricular tachycardias, palpitations, things that might come into your office. So we'll go over those. But this is a really good starting book. Thaler, not sure if it's quite deep enough. If you only had to pick one book, I would get this Garcia. Now be careful, he's got other books out, and I don't like them. I didn't even list them here. This old, I don't know if this is the first one that he made, but this book is awesome. It's out of print, but they still have them in stock. Students got them, a couple of students got them last quarter, so I know they're still around. So that's a great book. If you really want to get into it, we have Shu and Isa. These are great books, but they are way into the weeds deep. So I wouldn't recommend starting out with them. You'll be lost. So EKG, ECG, there's a lot of AKAs for that, developed by Einthoven back in the day. Out of respect for Einthoven, a lot of instructors just call it EKG. He's the one who coined that term, and then it later changed to ECG. So they're pretty much AKAs. Electrocardiogram. Okay, one of the most requested tests in medicine. My primary docs I've had many primary docs over the years. They all have their medical assistant will come in and hook that thing up on you. They're not very good at hooking it up sometimes. But nevertheless, the machines are pretty accurate these days. You still need to know what you're doing, though. I think the MDs have had a lot more. Probably had a full class of EKG, at least. We only have a couple hours. But anyway, not a couple hours. We just have 2 weeks. So it's considered the gold standard of diagnosing arrhythmias. Great for diagnosing myocardial infarctions. We've got to watch out for pericarditis, though, and STEMI myocardial infarctions. They both look similar on EKG. What is an EKG? It's just a recording of the heart's electrical activity made over a given time interval. I always update this every time I have class, and the price has dropped again. So this is a decent 12 lead. It has to be a 12 lead EKG. I think there are 6 leads and 4 leads, and little Apple Watch is like a 1 lead. But you should have a 12 lead to do this right. It's down to it was $2,000 a couple quarters ago. It's down to $1,400 now. I don't know if that's because of the COVID deal or don't know what it is. That's a good deal. What does it do? It shows us the average electrical current flow through the heart's conduction system. And there's one for the atria and there's one for the ventricles. So it's an average of current flow. Who cares about the average of current flow? Well, most people haven't. We know their current flows down to the left pocket, to the southeast. And yeah, but diseases of the heart like left ventricular hypertrophy or valvular disease or bundle blocks, they can all change that average flow of current in different ways that we can see on EKG. Diseases of the heart can change it as well. What can be gained? So you can tell the level of heart function. Mechanical function, are the valves working right? Really good at showing the size of the heart. We'll learn how to distinguish right and left ventricular hypertrophy the next lecture by looking at the EKGs. Heart's oxygen, you can look for myocardial ischemia, right? An inverse T wave. And of course, myocardial infarction, it can show up as elevated. Well, we'll look at some of the different ways. Pericarditis, so you can see a lot of stuff. You can see if bundle branches are working. How does it work? Well, there's nothing that insulates the anterior chest, so you can put some listening electrodes and you can listen to the electrical activity of the heart just fine. And by strategically placing electrodes around the heart, the current flow can be captured. You have to put them the same way every time so you get the same pattern of capture. That flow of electricity through the heart is printed out on paper and then stored on a hard drive. That recording is called a echocardiogram, ECG or EKG, electrocardiogram. We have paper that still, if you go into the ER, they still have a little paper roll that you can, a little graph paper that the graph is printed out, and docs can hand carry it. It's also captured in electronically in the ECG machine. And let's see. It records two important components of the heart: the electrical activity, or the average electricity, and the direction the current travels. So we have a time axis, which is the duration of the current. So that's, if this is the EKG like this, so the duration is measured as a duration, right? So a duration would be from here to here. And there's little boxes that we can count, and we could figure out the duration from the peak of the R waves here, right? And voltage is how high these waves are. How high is the QRS complex? So we can measure all that stuff. Sorry about that noise. We got the weed whackers out again, and I don't think it's going to be too bad this time. So here, this a lot of stars here. So these are the EKG units. You have to know these. I don't think you could pass this class without knowing these. So if you don't know them, I know Dr. Dole makes you memorize them. I'm pretty sure he does, so they should be easy. But one little box, you really only have to, for duration, you only have to memorize one little box. It's 0.4 seconds is one little box. There are 5 little boxes in one big box. So if you just remember 0.4, and if you can do multiplication, I mean, 0.04 times 2, that's 0.08. So 2 little boxes are 0.08. How many are 3 little boxes? Well, 3 times 0.4, that's 12. So 1.12 seconds, that's 3 little boxes. How about 4 little boxes? Well, that's 4, that's 16, so that's 0.16. How about 5 little boxes? 5 times 4 is 20, so it's 0.20. So 5 little boxes is 0.20 seconds, 4 is 0.16, 12 is 3 little boxes is 12 seconds, 2 little boxes is 8 seconds. Oh, there it is right there. Oh, duh. All right. So let's look at it. This is the classic grid here. And yeah, so one little box from here to here. Oops, I messed that up a little bit, but that's 0.04 seconds. 2 little boxes, 2 times 0.4. Do I have to do this? 0.08. You got the deal, right? So duration's pretty easy. So make sure you know duration. Now the voltage is along the y-axis, right? So that's this axis here. And it's even easier. So one little box, so just from here to here, that is 0.1 millivolts. Right? So how many is 2 little boxes? 0.2. How many is 3? 3, then 4, then 5. So it's really easy. Fortunately, we don't use that, or at least at this level, we're not going to use that too much. We are going to use duration, because you have to know the PR segment and the PR interval, and in order to distinguish different types of tachycardias and ectopic foci. We'll get to that. Surface, so the anterior surface of the heart, of course, is the right ventricle. Posterior surface is the left ventricle. Inferior surface is still mostly left ventricle. Left lateral surface is still left ventricle. So that left ventricle is a big chunk of the heart. Here's a nice PA view from behind of the heart, and this would be right at the level of the page. Here's the left atrium. This is going into the plane of the page. It's diving in, obliquely in. So this is pointing toward the apical impulse. This is what hits and creates the apical impulse right here. But this is all left ventricle, right? This is right ventricle. Here's the posterior interventricular septum. Kind of makes those differences. Okay, today's gold standard is the 12-lead EKG. So each lead, why would you have 12 leads? Because we have the same elephant. We have the same mean electrical axis going the same direction. There's the MEA. But if we put leads in different positions, then we get a different look at the elephant moving, or the mean electrical axis flowing through the heart. We get different looks at it. Right? Some fun facts. 10 physical leads are placed with little sticky pads on the chest, the precordial region. 2 of the leads are actually made by the machine. So in a 12-lead EKG, there's actually 10 physical leads. There's not 12 leads. I've asked that question once, and people didn't do too good on that. But that's really easy to remember. You have to be 10 centimeters away from the heart with regard to the limb leads. Okay, you don't have to put them all the way down on your wrists and all the way down in your ankles. I had a EKG not too long ago, and the tech is putting them way down on my ankles. I'm like, what are you doing that for? I said, you can put them right down my ASISs. He's like, oh, you can? I said, yeah, you can. That's been 40 years ago since you haven't had to do that. Yeah, so you don't have to do that. Precordial leads go right over the chest. A lot of them are in that 5th intercostal space, which we've been talking about in lab. So here is the limb leads set up, the blue leads there. So you don't have to go all the way down the arms, just put them up there at the chest up there where the arm hooks to the chest is good. And then these can be down by the ASISs, down the abdomen. Again, you don't put them all the way down on your feet. And then, so these are chest leads, these are limb leads, the blue ones, and these are the chest leads here. And we start in the 4th intercostal space, and then we're going to jump into the 5th intercostal space. And we'll look at those a little more as we go, but those are called chest leads. Okay, limb leads, also called standard leads, and then we have precordial leads, also called chest leads. All right, so the chest leads look at the flow of electricity through the heart in a different plane. So those guys are actually placed in the axial plane. So they're kind of looking, if they had eyeballs, they'd be looking like this, anterior to posterior, each one of these things. They'd be looking anterior to posterior, kind of obliquely anterior to posterior. Maybe this one's lateral to medial. But that's the eyeball, that's the look, because these things are all watching. Positive lead watches the flow of current, and that's kind of how they look, right? And if all these lines will be in a horizontal or axial, or you remember what's the mnemonic to remember all those darn AKAs for an axial plane? It's something a lot of my students like to do. Chat. Cross-sectional, horizontal, axial, transverse. Those are all AKAs. All right. And what else do we need to say? In the coronal plane, all the limb leads are placed in the coronal plane. And those guys are all looking in the coronal plane. They're looking lateral to medial in this direction here. And when you get down here, they're looking inferior to superior. Got slides on that, I think. So the 6 limb leads, as I said, they view from a coronal plane. They actually are placed in that, but they look from the I to S, or lateral to medial view. More specifically, EKG sees the average electrical activity, the wave of depolarization going across the heart. In I to S, so that we can name leads by this, but there's I to S views, like AVF is a perfect inferior to superior view, and there's left to right views, that would be AVR, And there's right to left views, and that perfect example would be limb lead 1. Perfect lateral to medial view. I'll show you pictures in a second. Subdivisions, the limb leads actually are split up into 2 types. We have the standard limb leads, which are bipolar, and then we have unipolar augmented limb leads, which are computer generated. This, I couldn't fit any more stars on here. I don't know how to tell you how important this is. You won't get an A for sure on this class if you don't understand this. In order to describe how the signal of heart flows through the atria and through the ventricles, we have to have something to reference that flow of electricity through. And so they came up with this hexaxial reference system. Normally the flow through the ventricles runs right down here to about 60 degrees, right toward the pocket. And, well, let me tell you what the system is. So it starts here at 0 degrees. So if this is a clock, if you go counterclockwise, negative 30 degrees is here. Negative 60 degrees is here. Negative 90. Negative 120. And then negative 50 is over here. This is AVR. This is a lead over here looking. Right? But once you go once you go clockwise past the 0 degree mark, then you're in the positive domain. So you're 60, 90, 120. That's really the only ones you need to know. It's limb lead 2. It's right here. It's the star of the show, as we'll see. I call this the peeper. This one's looking like straight up. This is AVF, floor, meaning the floor lookup. And this is limb lead 3 over here at 120 degrees. You've absolutely got to memorize these. We'll get to them. All right, this view that these cameras are all going to be placed in these places, like limb lead 2 is going to be placed right here looking this way. The way it looks, that's called the angle of orientation. The angle of orientation. Okay. And the lead that looks, the lead that gives us an angle of orientation, that is always the positive lead. Right? What is recorded, that is the average flow of current. Current swirls through the heart. It doesn't flow right toward the pocket perfectly. It swirls in different directions. But the computer averages it out, so it gives us an average flow of current. That's the point of that slide. Another really important, I'm going to assume you know what this is. I'm sure Dr. Doe talked about it, the mean electrical axis, which has got a whole bunch of AKAs. We have the MEA, the mean electrical axis. We have the axis. We have the mean electrical vector. A lot of times you'll see this word vector. That means they're talking about an MEA. The QRS vector electrical axis. Vector of depolarization, vector of current flow, vector of depolarization. I'd like to just use physiologist. How about just the wave of depolarization? Why not? But that's kind of slang, I guess. So what is it? It's the average direction of current flow through the ventricles or through the atria, whatever you want to look at. Okay, so here's normal. You can map the heart. The current is really flowing in many different directions, but the machine averages out the current. We're not looking at the atria, so forget this over here. We're just looking at the mean ventricular axis. But that's, when you say MEA, mean electrical axis, you really should say the MEA of the ventricles, the MEA of the atria. If you ever see a question that just says the mean electrical axis or the vector of depolarization, assume it's ventricular, right? Don't go atrial, because there's a separate atrial mean electrical axis as well. And that one's actually a little bit more, not that far, I drew it too far. It's probably about this far. It's east-southeast. So it's a little more counterclockwise than the mean electrical axis of the ventricles. But if you see MEA, assume we're talking about ventricles. Everybody good with that? Okay, let's see. Let's have to see. I need to get a clock, right? I never know what time it is. 3 standard limb leads. So let's meet these exactly. I kind of told you a little bit. But these are bipolar. These are made on Einthoven's triangle. They form a quadrilateral triangle. And the right leg is always the ground. Let's just look at it. Let's just look at them. So here they are. There's limb lead 1. You have got to look at all these stars. You've got to memorize these. Limb lead 1, 2, and 3. And you need to know what their angle of orientation is. Where is their view coming from? Where are they looking? So left arm is positive. I'm not so concerned about that. But you do need to know their angle of orientation is 0 degrees. So this kind of starts us off. And that's in the coronal plane. Limb lead 2, this is the star of the show. The angle of orientation is 60 degrees. Okay, this is the one that's usually used as the rhythm strip. And it's probably, if you had to only look at one lead, this is the one you probably looked at when you're in the physiology lab back in first quarter. And then limb lead 3, its angle of orientation is positive 120 degrees. Okay, here's the kind of the cartoon of the triangle. The angle of orientation of limb lead 2 is right there at 60 degrees. The angle of orientation of limb lead 3 is right here at 120 degrees. There's limb lead 1 at 0 degrees. This is probably a better picture like this one, but you got to memorize this stuff. So where's the camera in limb lead 1? It's looking this way. This is the way it looks. So it's watching the current flow like this. So the current's not heading straight. It's kind of heading obliquely to it, and that makes it a different waveform. This one is looking, when the current usually flows about like that. So limb lead 2, its angle of orientation is 60 degrees. The current's almost heading straight at it. And then limb lead 3, the current still usually goes like that. So this one's usually perpendicular to the current, perpendicular-ish. Maybe perfectly, maybe not. And I'll show you how to tell those in the next class. Important class, the next class. I guess I'm going to say, don't miss I always warn students, don't miss the next class. You'll be lost. But you'll always have these on YouTube now. Okay, there's limb lead 3 right there, kind of toward the right pocket. Right, its angle of orientation is 120 degrees. Right, and again, all these leads, they have different, it's the same flow through the ventricle, but they all will show you a different wave because they all have different angles of orientation. And different diseases can screw up those angles or the waveform that they draw is different depending on what the disease is. Okay, everything we said. There's maybe limb lead 1 there. Maybe that's limb lead, I guess this is AVF. I guess that's a small a, it should be. This would probably be AVR. Right, that's got kind of a weird view of the elephant moving toward limb lead 2. I guess should be go more like that. Okay, there's Marilyn Monroe. I guess that's the star of the show, or back in the day she was the star of the show. Limb lead 2 is usually the star of the show. It's placed at about 60 degrees as its angle of orientation, and that is usually, in most but not all people's hearts, that is the interventricular septum. That's the right and left bundle branch. Bring the current down the ventricles that way, and so this is a straight-on shot. And that's, with this limb lead, this is the one they usually draw in the books, where you have the P wave, and then you have PR segment, You have a Q wave, R wave, S wave, right? And then the T wave. This waveform is from this lead. That's what it usually looks like. They never tell you about these other leads, what they look like, and we'll get into that. Here is a typical rhythm tracing, rhythm strip that we'll be looking at. In fact, notice how here's limb lead 1's angle of orientation. There's limb lead 1, and this is how it sees the elephant moving across the heart. It draws this picture. Limb lead 2 sees it like this. Notice the QRS complex is getting close to biphasic. Notice the QRS complex over here is more like you see it in your books. The R wave is quite tall. The S wave is quite short. Limb lead 3. Now look at it. The R wave is tiny. It's almost gone. The S wave is huge. How come these are all different? Because they all have different angles of orientation. And notice how limb lead 2 is usually the rhythm strip, and this just runs and runs and runs. Notice these are all short little segments. Here's AVR, AVL, AVF. These are all the limb leads right here in this area. Right? There's V1, V2, V3, V4, V5, 6. These are the chest leads over here. But down here at the bottom, we have to have a way to count the speed of the heart. I mean, the computer will do that, but if you want to count the speed, you want to look for arrhythmias. You want to make sure that these R waves, peaks of these R waves, are all the same in palpitations or premature atrial contractions or junctional contractions. You'll see one here. You'll see a messing up of that RR interval. So you can look through it here. Okay. The augmented leads, let's talk about them. These are sometimes called Goldberg's augmented leads. So Goldberg kind of picked up the ball that Einthoven dropped. And not that he dropped the ball. I mean, he was brilliant at figuring this stuff out. But he's getting old, and Goldberg took things on around World War II, and he figured out how he could make the machine generate 3 more leads, unipolar leads. And those are called the augmented leads. And they are different. What are they? They give us different looks at that same elephant walking across the heart. So the more looks we have, the better. Sometimes you can only see pathology in one lead. All the other leads will look normal, but one lead looks screwed up. And so that's why you have to have these. They're all unipolar. Yep, they're still viewing the heart from a coronal plane. So here they are. So AVL, AVR, AVF. What are the angle of orientations on our little circle chart? -30 is AVL. AVR is way over. It's one of the only true views we have of the right side. Limb lead 1 can show that as well. Its angle of orientation is -150. And AVF, angle of orientation, this is the peeper because it's looking straight up. That is AVF. And its angle of orientation is 90 degrees. Right? So here's AVF would be looking up like that. I don't like that. I like this better. So here's the peeper. AVF is looking straight up. Remember, the elephant is still moving the same direction, but it's just got a little different view of the elephant. Look at AVR, though. That's actually going to show the current going almost straight away from it. So everything's going to be backwards in that lead. And then the current still goes the same way, but the angle of orientation of AVL is this way. I don't know why they have those arrows pointed that way. Right, so lots of stars. Make sure you memorize this. Stick this up on your refrigerator. You definitely need to have this thing memorized. Okay, I won't go through them, but I will. I mean, here they are. This is limb lead 1 here. Star of the show, limb lead 2. Peeper, AVF is here. Limb lead 3 is right there. Its angle of orientation is 120 degrees. AVL, its angle of orientation is negative 30 degrees. And then we have one more, AVR, way over here. It sees the elephant moving away from it, so its angle of orientation is minus 150 degrees. Okay, 6 chest leads. So these are called precordial leads. I tend to call them chest leads, but precordial leads, probably a better thing to call them, better to test you on. If I say chest leads, you'll know. Well, they all go in the chest, though. So designated V1 through V6. You can actually do a 18 electrode ECG with adding 6 more V leads, chest leads, if you want to see the backside of the heart more, if you want to look at the right ventricle more. I think there's a 24 lead as well, way beyond our scope though. So these all have angles of orientations that look at the heart through the axial plane. So they're looking this way, A to P, A to P. A lot of them are just A to P, and then it gets a little bleak over here. But we are in the axial plane. All right, here's somebody try to draw these V1, these looks of the heart. What are they good for? They're really good at picking up myocardial infarctions, differentiating a right from left bundle branch block. I usually don't have time to get into the bundle branch blocks, but I think I have old YouTube videos on those. Gives us the best view of the P wave, especially V1. It's pretty good at looking at the P wave. And yep, here's the placement. Let's just look at you can read that. Let's just look at this picture. So this is the 4th intercostal space. So V1 is placed right here, left or in the right lower sternal border in the 4th intercostal space. This is in the left intercostal space, right intercostal space, left parasternal border. No, I'm still sorry. Right, this is right. Right parasternal border, 4th intercostal space, that's V1. Left parasternal border, 4th intercostal space is V2. Then you skip V3, put V4 in our midclavicular line, 5th intercostal space, right? That should sound familiar. That's the apical impulse region, or the mitral auscultation region. And then you just stick V3 right over the rib, right in a straight line between these. Then forget 5 and go to the mid-axillary line in the 5th intercostal space. Actually, you're getting probably close to the 6th intercostal space. Put that and then put V5 right in between them. That'll be in the anterior axillary line. This will be in the mid-axillary line. Got it? And here's just another kind of an overhead view. They're all looking like this would be, these are all looking A to P. This would be perfectly A to P. But you can see what parts of the heart they look at. V1 looks at the right side of the heart. V2 sees a little of the right side, but it's starting to see more of the interventricular septum here. V3 sees right down the interventricular septum. V4, V5, and V6 all see the left ventricle. V4 is also the apex of the heart, so that's a good one to look at. Right, everything I just said. How about the chest lead groupings? So V2, V3, and V4 are seen in the anterior, are considered anterior heart leads. V5 and V6 see the left lateral heart. That's the lateral group. This is the anterior group. I've asked this question before. Who's the anterior group of chest leads? That would be who sees the anterior part of the heart. That's V1, V2, or V2, V3, V4. Who sees the left lateral group, or what's the left lateral group? That's V5 and V6. And V1 all by itself is the right group. Now this is where I usually stop. Let's see. You can probably do just a couple more. So, and we've talked about this, but parts of the EKG waveform, isoelectric line, Well, let's just go through it, shall we? You can read that. Let's look at it. Remember I said before the isoelectric line is where the heart is electrically quiet. So you can, we got a U wave in here. And again, this is limb lead 2. This is drawn via the eyes of limb lead 2 as the flow of electricity goes through the atria and then through the ventricles. So this is where this comes from. So we have from here, the start of the P wave, to the end of the P wave. That's called the PR interval, and we'll learn how long that's supposed to be. PR segment is the flat, electrically silent part of the PR interval. This is actually important. If you don't see a PR interval, which we will show you some conditions, there's no PR interval. Those patients probably have a ectopic focus in the junctional region of the heart. Q wave is the first deflection below the isoelectric line. There's the down limb, there's the up limb. That's all Q wave, if you see one. Sometimes they're huge, sometimes they're not there at all. Once you get back to the isoelectric line, now you're on the up limb of the R wave, down limb of the R wave, until you get back to the isoelectric line. Drop under the isoelectric line, S wave, down limb, S wave, up limb. The J point is the point where the electrical activity, the depolarization activity is done. Then we have another quiet period called the ST segment. In reality, it's usually more like that, because this isn't usually symmetrical. It's more like that-ish. But that's the T wave. That's repolarization of the ventricles. And then we have a U wave. That's kind of beyond our scope. Okay, QRS interval is really important. That's just the start of the Q wave to the end of the S wave. QRS interval. We're not going to talk about the QT interval. The ST segment, we're just all I'm going to say about that is if it's elevated, I think I even talked about that, but that's a STEMI myocardial infarction versus pericarditis. We'll talk a lot about the PR interval and the PR segment, so make sure you know about that. Notice that AVR, remember that's that right kind of oddball. Notice how its QRS complex is upside down, right? And look at 1 or 2. Those are the ones that you're used to seeing. 3, the QRS complex is upright. Why is that? Well, because the current is flowing away. Remember, the angle of orientation is way over there, negative 150 degrees. It's on the right side of the heart, so the current's moving away. All these other limb leads, the current is moving toward it. It should be normally moving toward it. So therefore, that one's reversed. So is the P wave, so is the T wave. Why? Because the current's moving away from it. All right, let's stop right there. Don't miss this next lecture, I will warn you. All right, see you in the next lecture.